We don't need that, do we? Well, welcome to everyone who is on the call, and especially those who are just joining. I'll continue to invite or to admit people to our Zoom room. But welcome to our November Journal Club. We have two really fabulous speakers today, two articles that are being presented. So I'm Sing Pallett, the president of PulpMed Colorado. I will go ahead and introduce our first speaker, who is Dr. Leslie Eber. She is board certified in internal medicine and a certified medical director. She is the president-elect of PulpMed. And for us here in Colorado, she is the immediate past president of PulpMed Colorado and one of my very good friends. So Dr. Leslie Eber, could you go ahead and start?
Thank you so much. Thanks for having me today. It's always such an honor. So I'm going to be talking about an article from JAMA that I found really interesting and actually useful in my day-to-day practice. And it's from JAMA Insights, Communicating Medicine. And this one is Improving Patients' Treatment Expectations. And I think this is something that at least I struggle with every day, that patients or their families have these expectations of what's going to happen next or how successful a treatment's going to be. And it doesn't always align with what I think is going to happen or what they're wishing for. And so aligning those expectations and knowing how to have those conversations, I find to be very useful. And so there we go. Here's some of the article information. This is how to find the article on JAMA, and it's also an associated podcast, 19 minutes, very well worth it. All right. So why does this matter? This is really intuitive, of course, but it's always nice to just point out. Patients' expectations are linked to clinical outcomes. When patients have positive ideas about their treatment expectations, they have better outcomes. And also, if they have negative expectations, not only do they have worse outcomes, but they have more adverse events. And so that even includes with pharmacology. So this is based on research done in Germany by the authors. It was really well done, and they really cited a lot of the other data that would be compelling for us to take this 4 recommendations for communication strategy on talking about expectations with our patients and families. So the 4 recommendations are: number 1, to explore recommendations and experiences. What is the person coming to the table with? What kind of experiences have they had with previous treatments? Strengthening the patient-clinician relationship, of course, that's really essential. And they found, I thought this was really interesting, you have to be both warm and competent. You can't just be warm, and you can't just be competent. The third one is improving expectations, the power of positive thinking. And they were really clear that this is not all about rainbows and sunshine, that you have to be realistic, honest, but you certainly can frame the conversation to not just talk about all the side effects of a given treatment, but really a more balanced presentation. And then managing adverse effect expectations and personal control. So I thought we would go through each one of these. So exploring treatment recommendations and experiences, we really want to know what the patient and family member is thinking. Have they already gone through chemotherapy and then they're starting another round? Have they tried 2 other antidepressants and they have had bad outcomes? These are important information for us to understand when we go forward with our patients and the treatments that we're going to recommend. And so we want to know, what are your expectations of benefits, reductions of symptoms, increased quality of life, side effects, and then they tell you how to ask it. How much do you expect the treatment will help you? And are you concerned about any negative or side effects or risks? The second recommendation is strengthening the patient-clinician relationship. Of course, good relationships, we know that not only they lead to decrease in conflict or legal action, but they actually are associated with better outcomes. And when the patient perceives their clinicians as both warm and competent, you even have an additional better treatment outcomes. And so we really want to be good listeners. We want to do a lot of nonverbal listening and often do that motivational interviewing. So we repeat back from the patient. So what I'm hearing is you've tried 3 different medications for your depression and none of them have really worked out. Is that correct? So how do you distinguish between sounding competent and being kind of a jerk, being arrogant? We don't really want to have that be our MO. And they have some recommendations for that. We want to show our expertise in a really thoughtful and kind way, connecting the symptoms that they're feeling with the disease that we're going to provide the treatment for, and referring to the fact that we may have been treating this in other patients and what we've seen other patients' experiences. This shows our knowledge and expertise, but doesn't become, we are all knowing and godlike. Improving expectations with the power of positive thinking. So this one's a little bit tricky. This is the third one. Again, no rainbows and sunshine, but I love the two research data points that they presented, especially in the podcasts. They talk about patients who are experiencing pain and they're told that they're getting an effective pain medication. They actually feel less pain. Then in the second part, they're receiving the same pain and they're told that they're not receiving a really good pain medication, but they actually are. They actually perceive more pain. So the medication really didn't change. The pain stimulus didn't change, but their perception, their expectation of the pain medication and what they're expecting changed, and they felt more pain. Same with SSRIs and anxiety. When you tell somebody that this is going to help with their anxiety, they have better outcomes and less anxiety. So important to let the patients know that you believe that this recommendation, this treatment is going to help. That's why you're recommending it. And so they need to know that too. So they have a belief in not only you as a provider, but in what you're recommending for a treatment. Be honest, but you can't be manipulative. You don't want to be overly positive with your expectations, but realistic. And then discussing the gains and function first, rather than only the side effects. You can also do what they call a personal mental recovery map, which can be, hey, if we try this, these are some things that we're aiming towards. We hope that you can walk to the bathroom by yourself. That's why we want to do not only therapy, but some pain control. And we hope that this combination is really going to get you to where you want to go, your goals. Okay, so the last one, let's see here. Managing adverse effects, expectations, and personal control expectations. I think this is the hardest one. So we want to balance information about the side effects and the benefits, and we want to do the positive expectations first. We want to frame side effects in a very specific way. We can also frame the side effects that the medication is working. This is a trick that we learned from our vaccine hesitancy. When you have a side effect from the vaccine, it means that the vaccine is working and you're going to be protected. So it's almost a relief to know that that you've gotten a vaccine and it's working. I love the story for one of the docs who was in the initial vaccine studies for Moderna, and he didn't know if he was getting a placebo or the vaccine. This is very early on in COVID-19. And he said he was so thrilled when he woke up the next morning and felt terrible because he had like a little achiness and a fever, and he knew that he probably did not get the placebo, that he got the real thing, and that made him feel great. Discuss frequency of side effects. There's a difference that people receive if they say, oh, 90% of the people have no side effects versus 10% of the people have side effects. When people feel like there's a less risk of side effects, they actually feel less side effects. It's actually a one-to-one correlation. I always remind people that if you review the drug packaging inserts or you look online about Tylenol, it's all the negatives. It's all about the side effects, none of the positives. You would never take Tylenol if you read all of that as a patient or maybe even a clinician. And so making sure that we frame it so that people have confidence in the treatment that we are providing, that we believe that it may help and that we want to confer that to our patients, but we want to be honest. We want to talk about side effects and risks, but we want to do it second. And this is an opportunity to really be on the same page as our patients and have their goals of care and their priorities. We can honor them by showing that there are goals of care and our priorities as well. And then I think we are going to be able to move forward because people are going to have some realistic expectations. If a medication is going to have some side effects, we can be honest about that up front. And then we have a better rapport, a better form of trust with our patients. And so that's it.
Wonderful, thank you. I could see how managing expectations could be a very powerful skill. I hear sometimes people want to give their patients a placebo, but they feel that that's unethical, or you want to skip talking about the side effects, but that's kind of unethical too. Maybe managing expectations would be a proper way to improve the outcomes.
Yeah, I agree.
Any
If
questions?
anybody has any questions, I think I have like 4 more minutes before I turn it over to Tim. And thank you for inviting me.
Thank you.
Leslie, I think that was great. One of the things that I always, and this goes for providers as well as patients, is before you start the drug, ask them what they expect it to do.
Mhm.
And especially, I mean, it's the easiest way to get rid of like an Aricept or an Amenda. Their memory's going to come back and they're going to remember their grandkids. That's not a choice. So
Yeah.
you try to bring them back to reality for choices.
I really like that. One of the things you can also fold into these expectations is you can ask your patients, do you feel like you're on too many medications? And if they say yes, it's an opportunity for deprescribing. So I really like that idea, Greg. I think that asking patients what their expectations are and what their desires are can really facilitate us moving forward in almost a better, higher quality of care.
We could perhaps use it for advanced care planning too. Yeah.
Agreed.
Yeah. Any other questions or comments? All right, well, Dr. Tim Holahan is our next presenter. And Dr. Holahan is board certified in internal medicine and geriatrics and hospice palliative care. He is an associate professor at the University of Rochester, so he is joining us from New York. He is a medical director in skilled nursing facilities, and I know him as the chair of PulpMed's Public Policy Committee. Welcome, Tim. And thank you
Thanks.
for being.
Yes, thanks, Sing. And Leslie, again, that was, one thing, thanks for inviting me. And then also, Leslie, that was a great, I actually found that, I find those articles very interesting. They are very clinically helpful, in the end. And it's always good for me to not sound like a jerk. So that's always good. So it's a pleasure to be here. I hear so many great things about the Colorado Medical Directors Association, and being in New York, it's just a pleasure. Just so folks know, it's 2:40 in New York, and it is not snowing in Western New York, so that is still a very positive thing. All right, I'm gonna share. I just want to get this up, so let's see from the beginning. Does that look okay?
Yep, we can see the slides. Thank you.
Okay, perfect. All right. So thanks again for inviting me, Sing. And so the article I'll be talking about today is clinicians who practice primarily in nursing homes for residents with Alzheimer's disease and related dementias. So this was an interesting article, and it really looks at this term a little bit more in depth as a SNFist is what folks like to call it. But it's basically looking at clinicians who specifically practice in the nursing home setting and how that care of those people compares to people who aren't really practicing exclusively in nursing homes in terms of residents with Alzheimer's disease and related dementias. So here's the actual article itself. It was published in JAMA Health Forum. And I really like articles that are, I was a little bit on the same page as Leslie and Sing here. This came up this came across my desk and I was looking at it, found it interesting, but it also Sing and I think a couple other people brought it up in our national sort of little email chain too and said, that's interesting. We should talk more about this. And I love articles that, really can impact clinical care, obviously, but also impact policy, right? And sort of the work that we do in general and how do we do it better? So background and objectives. So per this study, that about 58% of nursing home residents have Alzheimer's disease or related dementias. Many face preventable hospitalizations and ED visits, as we know. So the study is really focusing on that also in terms of the data that it's obtaining. And SNFist, the way they defined as clinicians, so physicians and APPs whose practice is mainly in nursing homes. So I don't want folks to get confused. Sometimes people think of SNFist as only physicians, right? But they really looked at this as our APP colleagues as well as physicians who are only practicing in the nursing home setting. And the question really is do residents with Alzheimer's disease or other dementias cared for by SNFists have fewer avoidable hospitalizations or ED visits? And methods. I know this is a little bit of a loaded slide, but I tried to keep it pretty simple. So this is a retrospective cohort study, so it's you have to take it with that in mind. It was 2013, 2019 Medicare fee-for-service recipients merged with MDS data from a 20% national sample or so. So it's, again, I just want to highlight that again, it's fee-for-service. They did not include Medicare Advantage plan patients in this. It's age 65 or older, long stay residents, and they define those with stays of 100 days or longer in the same nursing home with no more than 10 consecutive days outside the facility. Again, observational. And the data, I'm also not like this big data guy. I apologize for like the data aficionados in the audience, but basically the other thing that they used in this, which I think is becoming fairly common in studies now, is using machine learning or AI to adjust for co-founders within the study. I won't get into too many details with that, but just know that they did do that. And then the final number of people they looked at is greater than 417,000 long stay ADRD residents, those Alzheimer's disease or related dementia residents. And how they define SNFist also, can kind of impact. Like there's not like a magic definition, right? But the way they did it was greater than or equal to 80% of visits in nursing homes. So that's how they did it for this study. And the main outcomes, hospitalizations and emergency department visits for ambulatory care sensitive conditions. And I don't know, just in case folks aren't familiar with that means, these ACS conditions are basically ICD-9 and 10 diagnoses that are basically considered preventable among long stay residents. So that's your classics like your diabetes, congestive heart failure, pneumonia, UTI, et cetera. They also did a few secondary analyses as well. They actually split and stratified the analysis for physicians and APPs, inclusion of physicians of any specialty and APPs, and use of proxy outcomes for in-place deaths, which I'll talk a little bit about, but it's a little tricky in the end. The main findings were in the patients they looked at, 58% received care from what they determined as SNFist. So practicing, remember that 80% or more in nursing home visits. And then what they looked at was then SNFist care in itself. So this is the main graph that shows what they were looking at in terms of the odds ratios for ACS, remember those diagnoses I talked about, hospitalization, and then they stratify that among physician and APP, among physician only, and among APP only. And they did the same thing for ED visit. And what they found was that with SNFist care in general, 7% lower odds of these hospitalizations, preventable hospitalizations and ED visits. And then they looked at specifically physicians, their SNFists, and they had 13% lower odds of hospitalizations. Now, I will say that a little bit, I don't know how much I want it, and I'll talk about this at the end as well, but there is that one area that shows higher risk, as you can see trends just among the APP only example, but I don't really know how to interpret that, to be honest with you. So many of our APPs are doing so much work there to prevent hospitalizations. I think maybe what it shows is if there are really APPs that are practicing, without like a lot of engagement with the team, with the physicians. I don't know if that's what that was or not. Maybe they're more likely to send folks out. I'm not sure. But for the most part, this really showed that people who only work in SNFs actually are preventing hospitalizations and ED visits. More deaths occurred in place. That may not be surprising, right? Because we're probably doing more goals of care, right? So I think that that makes sense. So what? So it suggests better continuity and familiarity within facilities. I think SNFist, is probably gaining traction. I'm sure we've heard about this for a few years now. At least I have. and what are the benefits of that? What are some of the negatives if folks have them? So I do think it shows, though, that there's more of an adoption, that maybe this is more of a specialty type arena, and in terms of area of healthcare that requires some more expertise, which I think is true, right? There's maybe people who work in this environment may anticipate problems before hospitalization or look at it differently. They are more they sort of understand the nursing home setting better. They know how to work in a team setting. They know more of the regulations around it as well. I think all those things have benefits. And if you don't really work in this setting routinely, you may not know it all. It encourages considering specialized nursing home clinicians, as I said, and it actually may guide staffing and value-based payment models. There's been a lot of talk of this at the national level, and I think it's important where we look at our folks who are really specifically practicing in nursing homes and how they're doing it and what they're doing to help guide a lot of these things. And of course, it could reduce hospital strain, improve quality of life for folks with Alzheimer's, dementia, and related dementia residents. Limitations and questions, though. I do have a few questions. I think it was a really cool study in the end. I like the concept of it and the way that they went about it. It is observational in the end, so it's not causation, right? You can't really take it to that next level in terms of correlation. And it was Medicare fee-for-service only, so you are carving out the Medicare Advantage plan population, and which is not necessarily the end of the world per se, but I do think you are sort of carving out that population, which you have to be aware of. The other thing that I kind of question a little bit too is the attribution, like the way they did it and the way they identified what a SNFist is through sort of this look back method. You may misidentify sometimes the primary clinician. Like, how did they actually try to do that and ensure that's accurate, right? When they're seen maybe by multiple people over, a prolonged period of time. I think it's probably pretty good, but it may not be error proof. And in the end, needs further details and data analysis, I think, regarding other patient subsets in the nursing homes. Remember, this is just for patients with dementia specifically. So I think it's important to look at all of our residents in nursing homes and see if the same effect would be seen. And my other question was the SNFists, the way they describe them, right? Like physicians or APPs, did they also, on top of that, receive training in geriatrics or post-acute care specifically, and how does that impact the results, right? Like, could we somehow tease that out? And actually, does it provide even more of an impact in terms of these preventable hospitalizations? I have no idea. In the end, I think it's more important that I always look at it like that, your facility, right? And I think folks that work mainly in nursing homes and they're just there more often, they know their facility, they know their nurses, they know the residents, and know, obviously, offense to our primary care colleagues that are getting pulled in 50 different directions, as we know. It's kind of crazy, but when you're working in this sort of realm, there's just so much to learn and know, and it changes constantly. So I was just curious about that and if it would impact results. And of course, medical directors, do they play a role at all in these facilities? So many of us that are medical directors, I'm sure we could, sympathize with that. Even we have such an active hand in some of these facilities. I think every medical director is different, but you could see sometimes those most difficult cases where the patient's going back and forth to the hospital all the time, or it's difficult goals of care, or there's some ethical concerns. The medical director does intervene in those situations, and they didn't really talk about the medical director. So I'm just curious if that also played a role and could have shifted the data one way or another if you had a really engaged medical director or you didn't. So I did list, that's the majority of what I wanted to talk about today. I did list some other studies at the end, and I'll share this with Singh, and she can spread it to the group. There's been some other studies for sure looking at this, and I think it's important to look at it, all the data as a whole. So these are just some other studies I'd point you to, really over the last 5 years that I think have some insights into this too. So yeah, with that, I'll hand it back to Singh. And thank you again for having me. And thank you for all the work you do. It's great to be here. So
It's our pleasure having you, Tim. Thank you. I'd love to see what questions people have. I have a quick question back on that
Sure.
slide where you showed the data.
Yeah.
Physicians, APPs, physicians plus APPs. So when you look at those, if you see that like the little wings that stick out, is that the confidence interval? Like,
Yes.
if it crosses over the middle line, does that mean that those results aren't to be trusted, or how would you interpret that?
I don't know, maybe not, I don't know if I'd say not to be trusted, but are definitely questionable in terms of significance, right? So that's how I would interpret it. Yeah.
Any questions or comments from the audience?
Well, Singh, given your position in life and what you're doing for your job, it seems, especially in Colorado, where we're so highly penetrated with Optum and longevity and so forth, it would seem like a real miss that they left that out.
Yeah,
I
I
mean,
think that
that is how you
we
survive.
focused on Medicare fee for service and probably based on the data set that they had access to.
Yeah.
Yeah, I agree. Like in the end, like that is, I mean, and actually, when I'm looking at this study too, there are going to be areas that you can't even apply the data to. Because, like, for instance, in Rochester, New York, we are like 85% Medicare Advantage plans, right? So, oh, yeah, it's bonkers where we are in terms of that sort of stretch in terms. So, we have tons of folks that are on Optum, we have tons of different I-SNP plans, different Care Medicare Advantage plans. So, I agree. Like that is a downside to the study itself. But yeah.
I wonder, Singh, do you know if your group has their own data at all with your iSNF? I wonder if that data would also be revealing as to the trends when you have nurse practitioners, PAs in the facility, 5 days a week, or,
Yeah.
a steady presence. Does that decrease hospitalizations as well?
Yeah, that would be great. I think that the data that iSNPs would look into are for people who are primarily practicing in nursing homes. So I don't have people on my team to compare it to because that's all my whole team does.
Mm.
And there's a reason we do that. It's because mostly we feel, and I think we have seen from studies like this one that Tim has presented, and perhaps some smaller ones that have compared different groups, that yeah, the better you know the environment and the people you're taking care of, the better outcomes you can get for them. I think that frequency matters too. Maybe someone is an excellent clinician, but they're only there once every 2 weeks versus someone else who's there every day. They're gonna teach a lot more.
Totally agree. Be interesting to kind of see that teased out even more. Like, is there a little bit of a, who knows, of a baseline threshold? It probably is hard to find, but I could see that making sense for sure. Yeah.
I wonder if there's any other planned data evaluations for, besides fee for service, but with the Medicare Advantage and seeing who's seeing these folks and how we can affect higher quality of care.
Yeah, I mean, that'd be interesting. I'm sure there is. And again, I kind of mentioned it briefly, but Leslie and Singh, just some of the obviously national policy work we're doing, the focus on value-based, payment models, right? Like, I think the data be very valuable, and show value of what we do, right? And how are you measuring quality and all those other things? So I think you're right on it. I don't know that off the top of my head. I'm sure there is, but I think more to come on this for sure. Yeah.
No, I'm sorry, I don't mean to imply there aren't any studies. I mean, there was a study in 2022 that was like based out of Harvard that compared people on iSNP programs to
Right.
patients who weren't, and they did go less frequently to the hospital. Was it because of the practitioners that they had? Was it because of other parts of the program? That I don't think that was specifically studied, whereas this one we're looking at today that Tim presented was specifically about the practitioners.
Right.
I mean, it seems like the take-home message here is when you have that expertise, when you're in the facility, you know how the facility works, whether you're nurse practitioner, PA, doc, that you're going to have a positive effect on those patients' lives, and they're going to go to hospital less.
Yep.
And Tim, I think you raised a great question about, these people who are SNFist, do they have additional training in geriatrics or in post-acute care? How would you even know that?
Right.
A geriatrics fellowship isn't the only way to determine who has that kind of training.
Correct.
And Paul is trying to provide a lot of it and find a way to designate who has that training or not.
Correct. Yep. I think that's interesting and obviously hard to tease out from this, but it's a good question, right? It could definitely impact things, I think.
It is the top of the hour. Are there any other questions or comments? Well, thank you, Dr. Holahan. Thank you, Dr. Eber. Great journal club today.
Thanks for
Sorry.
having